All right, good afternoon, everybody. We might make a start. I'm very aware we have a room full of busy people, so we'll make a start. I'd like to start by welcoming all of you who are here in the room, and to people who are joining us online, a very, very warm welcome to the launch of the Responding to Elder Abuse resources that were developed here at Peter Mac. It is my real pleasure to welcome you wherever you are joining, and to extend a very warm welcome to Mr. Gerard Mansour, who is the Commissioner for Senior Victorians, who's joining us this afternoon. So thank you, Commissioner, very much for your time in joining us. Before going on to talk about the work, I would like to acknowledge the traditional custodians of the land where we're all meeting here today in Parkville, the land of the Wurundjeri people of the Kulin Nation. Pay my respects to their elders, past, present and emerging, and to all of those of you joining online. Extend that respect and acknowledgement to traditional elders on the lands wherever you may be. So my name is Mai Krishnasamy. I'm Director of the Academic Nursing Unit here at Peter MacCallum Cancer Centre, and lucky enough to work with a wonderful team of nurse educators and nurse researchers. But I would particularly like to acknowledge the people named here on this slide who have been integrally involved with the development of this work from its outset, and particularly want to acknowledge the patients, family members and carers and healthcare professionals who've given their time and their expertise to help us get to this point and to develop and to launch the resources that you will hear about today. I'd like to particularly acknowledge Catherine McMurtry and Catherine Devereux, who have really put a huge amount of work and commitment into generating the resources that you will see as we go through this afternoon. So thank you both very, very much. Yeah, thanks, Jerry. We're here because 1 in 6 elder Australians will experience some form of elder abuse. It's an insidious and highly distressing problem. And you will hear more about that from the Commissioner later. But in 2021, late 2021, the Academic Nursing Unit was fortunate enough to have a research grant through Impact Philanthropy to really explore this issue with people affected by cancer, in particular older adults affected by cancer. And we had funds to develop what has become the first Australian co-designed or co-produced study. So a study that works with experts by experience, so the people who have lived experience, who've been generous enough to share with us what has happened to them and what they've observed and what they feel and what they view about elder abuse. And so we had the funding, and these were our study aims, to explore awareness of and attitudes towards identifying elder abuse in a busy, acute hospital environment, and really looking at that awareness and the willingness to talk about elder abuse amongst patients, carers and healthcare professionals. And having gained that insight and awareness, to then go on to develop resources that would help us raise awareness, not just amongst the staff about being open to those cues that something may not be right and how you respond confidently to that, but also to making sure that we raise awareness amongst our patients and our carers that this is a safe place to let us know that there's something troubling them and that they would like help with something. And so what did we do? We carried out, as I said, a collaborative study, and lots of our research here is very much directed by working with the people who are experiencing the problem that we're interested in, rather than researching on. It's very much a collaborative partnership. And we had wonderful consumers involved in all aspects of the research. So we worked with patients themselves, family members, carers, and of course, healthcare professionals to tell us what should be in the resources, not just in terms of content, but what they should look like, what we should be doing with them, how we could use them. And we got that data by audio recording focus groups and interviews, by really delving into some of that detail and using that information then to put into the content of some of the resources that you'll see today. So they were developed, the resources themselves, really through detailed consultation with consumers. They were developed, written, revised through an iterative process with people, so that we were confident that what you see today reflects what matters and responds to the needs of the people that we're trying to help here. Now, oops. hold that moment. What I'll show you now is a video that was developed by consumers for consumers. We were hoping that Peter Goley, who is one of our fabulous project team members, would be here to present it. Peter can't be here, but you will see him on the video. So although not in person, he is here with us, and I'd really like to acknowledge Peter's expertise. Now, I hope I haven't completely mucked up the IT by going back, so I'll try that again. Go.
Hello, I'm Peter Goulet, a Peter Mac melanoma patient. Recently, I've had the opportunity to be part of a study focusing on the sensitive and important topic of elder abuse. This Peter Mac study involved talking to older people with cancer and their carers, as well as staff, about how we can best support older people who are experiencing elder abuse. Elder abuse can happen in any family and in any relationship. Sometimes older people are unaware that they are being abused. Sometimes family members are unaware that what they are doing is actually elder abuse. Sadly, elder abuse is very common, with close to 1 in 7 older Australians experiencing some form of abuse. So, what is elder abuse? It starts with disrespect, and behaviours may become controlling or bullying. It is often about family members wanting to access an older person's money, their house or belongings. Neglecting older people's care and stopping them from contacting family and friends are also forms of abuse. Elder abuse is not just physical, and more often it is not. These behaviours can leave older people feeling depressed, fearful and ashamed. No wonder it's so hard to speak up, and that only 1/3 of people who experience elder abuse ever seek help. Many people are dependent on the person who is abusing them, and they worry about what might happen if they report it. Some people fear for their safety. Older parents may feel they are a nuisance and don't want to cause trouble, or they want to protect their children. Hospitals like Peter Mac have an important role to play in supporting people who are experiencing elder abuse. If you or someone you know is experiencing elder abuse, talk to someone you trust. At Peter Mac, confidential support is always available. It is always your right to make your own decisions about whether to tell someone. It won't be taken out of your hands. Peter Mac will listen and support you. And remember, everyone has the right to feel safe and to age with dignity.
So I'd like to thank Peter for so powerfully representing what we heard in the focus groups and the interviews. There will be more that you will hear later on, but it's now my pleasure to introduce our Acting Chief Executive Officer, Karen Fox. Thank you, Karen.
Thank you very much, Mai, and thank you, Peter, for that really touching video. I learn something new every day at Peter Mac, and I learned something new there too today. So thank you for the introduction, Mai, and good afternoon, everybody. I am Karen Fox. I'm the Acting Chief Executive at Peter Mac, and normally the Chief Operating Officer here at Peter Mac, and it's my absolute pleasure to be present here today for the launching of these incredible resources. Here at Peter Mac, we take all kinds of abuse and harassment really seriously. We're committed to identifying and responding to elder abuse in all of its forms, which is unfortunately all too common. It's a common experience for many older people. It's critical that we're working continually and continuously to create and maintain an environment where older adults are valued, respected, and protected from abuse. With the patient at the centre of everything we do here at Peter Mac, we all need to be able to identify anything that might be getting in the way of their treatment or care. I think the challenge is that elder abuse can just be so invisible to the person experiencing it in some ways too, as demonstrated in that video, and that it can take so many forms. I've no doubt these resources will be a great help for clinicians needing to have really difficult conversations with some of our most vulnerable patients and their families as well. And I hope they'll create more opportunities for older people facing abuse to disclose or to access assistance. Developed in collaboration with Peter Mac consumers and in conjunction with the Reason study, it's amazing to see how authentic these conversations feel. I want to thank my Krish Nazami. I always stumble when I say that, and I am somebody whose maiden name was Ustinowski, so I'm very used to people mispronouncing my name too, and her collaborators as well on this project, Catherine McMutry and Catherine Devereaux, for drawing attention to this important issue and developing such robust supports in response. We're really fortunate to be able to take advantage of your unique nurses' perspective in researching and addressing issues like elder abuse. You've seen it, you've experienced it, you've felt it with patients and their families, and that's something that's really enriched the resources that you've provided. I also want to extend sincere thanks, really sincere thanks to the consumers and clinicians who gave so generously their time and perspectives to aid in the development of these resources. Nurse-led research is making such important contributions to our broad range of cancer research at Peter Mac, and I want to acknowledge the excellent work being done across so many areas in the academic nursing unit. I'm proud to see research and resources like these coming out of Peter Mac. It's something that we feel incredibly proud of, and proud of you in putting these resources together. I look forward to seeing them shared with other members of the cancer and healthcare communities throughout Australia, Victoria, and the rest of the world, where I'm sure they will have a really great impact. So well done. I would now like to extend a very warm Peter Mac welcome to Gerard Mansour, Commissioner for Senior Victorians and Ambassador for Elder Abuse Prevention, to deliver today's keynote address. Mr. Mansour is a highly respected and passionate advocate for the needs of older people. He's dedicated much of his career to improving the lives of senior Victorians and raising awareness about elder abuse. In 2013, Mr. Mansour was appointed as the first ever Commissioner for Senior Victorians, providing advice to the Victorian Government on issues relevant to senior Victorians. In 2016, his role was expanded to include acting as an ambassador for elder abuse prevention, giving older victims of family violence a voice and raising community awareness of elder abuse. Mr. Mansour's current priorities include isolation and loneliness of older people, prevention and response to elder abuse, and what it means to age well. We're really fortunate to have you here with us today, and we're grateful for your ongoing dedication and hard work towards improving the lives of older people in our community. Thank you, Mr. Mansour, firstly for being with us here today, but even more importantly for everything you do to progress a civil society and the community and keep people safe. Thank you and welcome.
Thank you very much for that lovely warm welcome, and I'd like to start by acknowledging the traditional owners of the lands that we're meeting on today and their elders past and present, and just also acknowledge what a fantastic leadership the Aboriginal community, First Nations people show us about how to treat elders. We've got a lot to learn from the role and the perception that they have about the role of elders. I'd like to congratulate you on the work that you've done. Well, how fantastic to get towards the end of a project. And I know great leadership by Peter Mac to think about the fact that people, when they're dealing with critical issues in their lives like cancer, can still be vulnerable for other things that happen in their lives. So great recognition by you, and appreciate that. I'd like to start today's address by reflecting a little bit on how our community sees older people. And I think a really important part of the message that I typically give to older people is we need to think about the journey of ageing as through a rights paradigm and a rights lens. Just because we get older, we have no less rights than we do at any other point of our life. One of the most common comments older people talk to me about, I get a chance to meet many older people in our community. I published a report recently about ageing well. I've published reports about isolation and loneliness. And when I say to older people, tell me the challenges that might confront you when you get older, the most common single word that appears in their sentences is the word invisible. And so elder abuse needs to be looked through that lens. Did you notice in the video there in the comments that May made, only 1/3 of older people who are experiencing elder abuse actually reach out for support. And so if there's one thing you take away today as staff or as older people or carers or supporters wrapping around them, that's the thing we can have an impact on. Because of course, people aren't going to get a pathway to support or assistance if they don't actually reach out for support. So I think that's a really important starting point. And it starts really from this rights paradigm, a conversation with older people that just because you're getting older, you have no less rights and you have a right to be treated and respected. And elder abuse comes out of that sort of paradigm. So what's elder abuse? I thought it'd be good just to reflect for a few minutes about elder abuse and what it is. So it's any act occurring within a relationship of trust which causes harm or distress to an older person. Typically, one of the differences between elder abuse and other forms of abuse is that we hear a lot in the media about gender-based violence as a key driver for family violence in Victoria. Now, of course, that also applies to older people. Just because you get older, you're not less likely to experience some type of gender-based violence. But interestingly, the research in elder abuse tells us that the predominant abusers are actually the family members, the siblings, the children, the adult children, the grandchildren, family and friends wrapped around an older person. And so gender-based violence, yes, it needs to be on our radar, but we need to think much more widely about violence and the impact of what it is from an older person's point of view. So here are the 6 main types of abuse. So I thought it'd be good just to quickly touch base on what they are. So when we talk about elder abuse, what are we actually talking about? Well, the most common form of abuse on one single thing is financial abuse. And Peter, what a great advocate. I mean, I do a fair bit of media. I'm fortunate to do that. And they would say, Peter is great talent. So I don't know where you got him from, but brilliant to have him as your front of the video. So financial abuse is the most common form of abuse, but what tends to happen is you have a combination of abuses. A typical experience for an older person would be an adult child wants to access some of their cash. Could be for a whole range of reasons. Sometimes it's related to an adult child moving back home. So they may have had a relationship breakup and they see mum or dad as the person of last resort and they go back home. And of course, the likelihood of risk does increase, doesn't it, in that environment? And particularly, one of the things that a perpetrator of abuse of any form will do is they'll try to isolate an older person from the people around them. And so that's one of the signs that I'd suggest is a really positive sign to look out for. If you're talking to an older person that's talking in the language of isolation, disconnection, then your radar goes up. That's increasing the risk and the risk factors. And so from an abuse perspective, the most common form of abuse is financial, but it's most typically linked with social and emotional or psychological abuse. So the perpetrator will isolate an older person, and you'll often hear other family members saying, it's really strange. Mum or dad doesn't ring me much anymore. Since my brother or my sister went back home, I don't hear much from mum anymore. again, a bit of a warning sign, what's happening? And often you can't necessarily assume there's a problem, but it's heightening up our ability to ask some questions. Physical abuse, sexual abuse, in the reported abuse areas tend to come up lower. So when you look at the data in the prevalence study that was referred to, I've got a little word of caution about that. And my caution is, could that just be a representation of underreporting? So don't necessarily assume that physical and sexual abuse aren't occurring, but the data shows that it's a little bit less than the other types of abuse and neglect there as well. I'd like to talk about some of the practical things that we can all do from a prevention and a tips point of view. And then I'd like to make a couple of comments about what I see as the role of ageism. But before I do that, I wanted to make a different comment. And that's that because when we have a conversation about the risk of families as abusers, the thing we don't want to do is make an assumption that, oh, therefore all families are going to be potential abusers. The data says that 5 in 6 older people aren't having this experience. So that's really positive. The challenge we've got is we don't know which 5 or 6 or 1 of 6 are the risk factors. And so we need to have a really open mind. But I would like to, particularly in the context of cancer, acknowledge the role of families and carers and the great work of the staff in supporting people through that critical time. But this is the challenge with elder abuse. And like other forms of violence, none of us really know as we get older, when we travel through that journey of getting older, what are the set of factors in our life that might make us vulnerable? It's often very difficult for an adult, an older person, to prepare themselves against the risk of elder abuse, because it's things happening in other people's lives around them that tend to be the risk factors that are impacting on them. So as I go through the tips, I just wanted to acknowledge the really positive role that most families play. The first one is a zero tolerance. We should talk about elder abuse in the same way that we talk about other forms of family violence. It's simply not acceptable. Older people have rights. Those rights don't dissipate just because somebody gets older. Connections. This is when I've got groups of older people and I talk to them, this is the single best prevention measure any older person can have, is staying connected with their friends and their family and the loved ones. Just closely behind that is their connection to professional supports and organisations as they get older. Connections to Peter Mac, connections to home care services, connections to other supports in their lives is a really critical part of the prevention that they can put in place. And so if people start to talk to you about living alone, feeling isolated, here's a great opportunity to talk with them about the things they might be able to do. This is the number one prevention factor that I've identified from an older person. Don't allow them to become isolated from the supports that exist in our community. Seek advice if you have concerns. So this is a great thing for all of us. Because elder abuse takes so many different forms, we don't talk about it very much. We don't see much in the media about it. Those 6 areas of abuse can be all complex, and often an older person doesn't necessarily understand. So if I give you an example, I was at a meeting recently with older people, and the difficulty they were having is the grandchild was coming to them and putting to them, oh, it's your job to support me. Trying to use that sort of role of support against them. So it can be very complex for an older person. They think, oh, I should be doing it. Or if my adult son's the abuser, have I failed as a parent? What have I done to bring this upon myself? And that's why I say the rights paradigm is a really important one. Irrespective, you have a right to still be treated fairly and reasonably and not be subject to abuse. There are some things I talk with older people about future planning. There are some things we can think about. Lots of us, as we move towards the seniors' years and retirements, don't like to think about the fact that we might need supports one day. There's a real quest for us all to be as independent as possible. And so future planning is important for all of us, including older people. I talk with them about the practical documents. One of the protections for an older person that can be important is having these legal documents like powers of attorney, medical powers of attorney, so they don't lose control over decision making. So that the people that they appoint as their decision makers, if they start to face cognitive impairment, are the people they trust and the people that they have confidence in. Make their wishes known. Don't be pressured or intimidated. Confirm arrangements in writing. So one of the most common areas of abuse and why we've got so much financial abuse, Often abuse in this is a bit like a scam. You know, scams, they start small and they build up over time. So the adult son or daughter says, oh, can I borrow $100? No problem. Next time, can I borrow $1,000? Can I borrow $10,000? You know, so that's the sort of typical nature of abuse. And of course, there's nothing in writing. And so getting restitution becomes extremely difficult once the money is gone. Take care, particularly asset transfers are the area of most vulnerability for an older person. So if an older person comes in and said to you something about an adult son or daughter was wanting them to transfer their title, now your alarm bells go up in terms of risk factor. It's very, very difficult for older people to get justice once those things have gone. Because it links back to often there's a lack of written communication about that. And of course, if you're concerned, immediately contact 000. But I wanted to talk about what I think is one of the most significant drivers of elder abuse. Why is it that we have this form of abuse? Why is it that it takes this particular form? And how is it linked to the experience of people getting older? And I must say a key part of it is the way I think our community perceives people as they age. Because older people feel often devalued, the skills that they bring into the seniors' years aren't recognised in the same way at other points of their life. I think there's an opportunity for all of us to quietly challenge ourselves. Are we, in some forms, inadvertently ageist? Are there things that we do in our attitudes and our thinking? And if you think of the language, you know, that often represents in jokes and things like that, old fuddy-duddy, or you're over the hill, you're past it. So there's a whole narrative and language that often is coached in or couched in humour that really is a form of disrespect for older people. It can be about physical movement. It can be about impatience with older people. One of the most common forms and practical experiences that's been presented to me of the early signs of how the community can express ageism is actually by women. And in my meetings, often women, because I will be talking about it, and ageism as a term is a very new term, and so I often try to explore it and get examples of it. And so we're talking and giving, and I said, has anybody experienced anything like this? And one of the most common starting parts of the conversation is an older woman saying, something happened in a retail setting. I was just standing in a shop the other day, and it's just as if I wasn't there. You know, they served the younger people around me, and this particular lady said, oh, I've got a response to that. I said, oh, what's your response? She said, oh, I have a $50 note near the top of my purse, and I just pull it out and say, oh, I'm here. So there's a very real experience of older people in retail settings, and I've just done some more research into this, and that was the #1 experience. Interestingly, and this was a bit surprising to me, just below that was the experience in healthcare settings. And the most common language that they used is they felt that they were too often told, oh, what you're experiencing is just part of getting older. And it was often associated with conversations around mental health. Oh, you've lost your marbles. And there was a sense that, you know, my needs aren't being treated in the same way because I'm older. And at the front line of that were often conversations about GPs, where they were maybe trying to have a conversation about emerging mental health issues, isolation, and they walked out with a medical pill and that was it. You know, so their sense was that in a healthcare setting, a number of people sharing experiences of inadvertent ageism. I don't think anybody sets out to do that, but I think there's a challenge for us all to reflect on our practice and our language. In a workplace, I think that's one of the most common public challenges. Often on the radio, you'll hear an older person ring in and say, I'm 58, I lost my job a year ago. I've applied for 27 jobs and I can't get an interview. Every time people see my age, I'm not even getting into the chance to have an interview. So in workplace settings, it's very common. And so I just wanted to couch today and our considerations in the fact that there is a form of ageism that exists in our community. We don't talk about it enough in the same way we don't talk as much about elder abuse. Sometimes it takes that structural form. Sometimes it takes an individual form. And sadly, from my point of view, the most challenging part, sometimes it takes an internalized form. And what I mean by that is that older people bring on themselves a stigma that if I ask for help and assistance, somehow I've failed. I shouldn't need to get to that point. And it's often represented in a time between when an older person's recognising they need some help and assistance and support. Often it'll be 2 or 3 or 4 years before they act on that. And the most common example of that is think about the walker frame. When I say to older people, share their experiences of a walker frame, they'll often say to me, I wish I'd have done that 3 or 4 years ago. Everybody around them knew that they should have done it 3 or 4 years ago. And when they generously share with me the reason why, it'll often be the stigma that they perceive that's associated with the fact that they've got to use something like that. And so internalized ageism is something to look out for. What it is when older people are starting to devalue themselves and their contribution, and professionals and carers and people wrapping around them can play a really positive support role for them in that situation. So I finished by giving my congratulations to Peter Mac. What a fantastic piece of work, embracing it, dealing with the challenge. None of us like to think about the fact we might be on the journey of cancer. None of us like to think that we might be on the journey of elder abuse, and to bring those two together, congratulations on your bravery on doing that and coming up with some real clear strategies to address what would be two of the most vulnerable things in someone's life, to be dealing with cancer and then deal with elder abuse at the same time. That would be a very challenging life situation. And I finished that there's I do a number of social media posts. I have different reports. If you'd like to connect with me in the future and the things that I say in the future, I'd welcome that. Congratulations.
Thank you, Commissioner, for your very insightful presentation and thought-provoking words around the challenges of both elder abuse and ageism. I'll just introduce myself. My name is Catherine Devereaux. I'm one of the Catherines of the 2 project officers leading the Reason study. This has been a really interesting and important study to work on, and we're really pleased that our project is able to contribute to some awareness raising around this important issue. I just want to talk to you very briefly about the resources that we've developed and why we did that and how we did that before we show you one of the resources. When we spoke to consumers, there was 18 consumers in our study, and it's so lovely to have quite a lot of them in the room today. Really fantastic to have your support in an ongoing way. They told us if they were in a situation where they were at risk of elder abuse, they'd want to have a very gentle conversation with a health professional who was confident and whom they trusted. They didn't want to have an interrogation. They also told us that education of staff was really important, and that would be a really important way to kind of invest our efforts in this project. When we talked to health professionals other than social workers, they said, well, we really pick up when things are not quite right between the patient and the carer, but we're not so clear about the next steps and what to do. So people said things like, staff said, this is a really complex issue. It is part of our duty of care, but it's something that we're not good at. So with those strong pieces of data, we felt that it would be really useful to contribute to that capacity building around raising confidence of staff. So from our data, we drafted some scenarios, and they were very much based on the stories that we heard and the input that we had from both health professionals and consumers. And we based it on the more common types of elder abuse, financial and emotional elder abuse. And we then had a co-design process with the social work team, the nursing team, and Peter Goulet, our consumer member on the project team, to really refine those resources. We needed to have actors play the patients in these scenarios. So we went to our networks to source some actors who fitted into the category that we needed. And it's really lovely to have Barb and Brian here today, who are our actors in the filmed resources. We also wanted to use Peter Mac role models as the clinicians in the 2 films. So really fantastic that Amu Nandi braved being part of that. Amu was one of our participants as well. And we felt that, you know, that Amu's style, her very sensitive style, would work really well on screen. And we also sourced, after a couple of tries, a doctor who, Brian Kelly, who did a fantastic job in the role. That little graphic there is really just a kind of an overview of what we were trying to do. As I said, there were 2 different types of abuse. In one of the scenarios, the financial scenario, Brian, the older patient, who was Stephen in the video, agrees to having a referral to social work for support. And in the other scenario, the patient is wary about being supported at the time that the conversation takes place. So the staff member, Amu, checks in on the patient's safety. So really great to have Peter Mac role models. So that sense that we as health professionals can learn from other health professionals at Peter Mac. We also wanted to make this as authentic as possible. So Amu and everyone had a script that we wanted them to work to fairly closely, but we still wanted to hear their voice in how they would converse with an older person. So we're very pleased to be able to share one of the resources with you. So this is Emotional Elder Abuse, a Sensitive Conversation.
Hi, Joan.
Hello.
It's nice to see you.
Thank you.
Are you on your own today?
Oh, no, my son Mark's here. He's on the phone. I think he's just talking to his work for a while.
Okay. So how are you going at the moment?
I'm doing okay.
Actually, while Mark's not here, I actually did want to talk to you about something. Is that okay?
Yes, okay.
I've noticed that since Mark's been bringing you in for treatment, that you haven't really seemed quite yourself. And I've noticed him talking over the top of you, and you seem a little bit quieter. Is that normal behavior for him?
He gets very frustrated with me. He's a busy person. He's impatient.
What do you mean by impatient?
Well, he's having a few troubles at home and he's under a lot of pressure, and I do take up a lot of his time. He gets very angry with me. I'm too slow. I am a burden.
That sounds very tough, Joan. And it sounds like Mark's under quite a lot of pressure himself, but it doesn't make it okay for him to treat you like this. Does his behavior ever make you feel scared?
My neighbour says this too, that Mark speaks to me badly.
It's important that you feel safe, Joan. The social workers here actually might be able to talk to you about your concerns with Mark and his behaviour. Would you consider a referral to social work?
Oh, no, I can't. Mark's the only one that can help me. I depend on him for a lot of things.
That must feel quite tough to feel that you have to depend on Mark for everything.
I don't want to get him into trouble. There's no one else to look after me and help me around the house. I know he would never hit me.
You sound quite worried, Joan. Social work can actually help you with other things as well, not just talking through these sorts of issues. They can help with home help and organising things that you might need. Would that be helpful?
Yes, that might help. Well, to be honest, it has been worrying me. I'll think about it.
Yeah, you absolutely don't have to make a social work referral today, but just remember that you can always talk to a nurse or a social worker about any of these concerns if you need to. I'll write down our hospital switchboard number for you, actually. Here, take that with you.
Thank you.
Can I just check that you feel safe to go home today? Is there anyone that you can call if you ever needed help immediately when you go home?
Well, I could contact my neighbour. I can ring her or knock on the door.
Yeah, that's good that you've got someone there to help you.
She's a good friend.
I know it's really hard to open up about these sorts of things, but thank you for telling me everything that's been going on and for being honest about it. It's just important that you feel safe, and we can help organize anything that you might need.
I get quite a visceral response when I see that. I just think it's such a powerful example of an empathic and caring and responsible, responsive and respectful conversation. And it just demonstrates the agency and the safety of the patient being front and centre. So Amu, thank you so much for being such a wonderful role model. And Barb, thank you so much for being a wonderful Joan. So just to introduce myself, I'm Catherine McMutry, or commonly known, at least over the last 12 months, as one of the Catherines, the other Catherine. And as Kath earlier said, it's been a wonderful opportunity and an honour actually being involved in this research, and as a nurse being involved in, my first kind of major bit of research. It's been such a wonderful opportunity. So my thank you for that opportunity. So now just a few words on the implementation, or the potential implementation of our resources. So they will be integrated into consumer and clinician education initiatives. So the consumer video will sit within the Peter Mac Cancer School. So that's a site on the internet, Peter Mac Internet, that is for patient and carers. So that's where that one will go. And the health professional videos are designed to be flexible in that, that we feel that there's a great opportunity for them to be used in a variety of ways and settings, both online and face-to-face. But it's probably worth saying upfront that when the health professionals that we spoke to, there were 18 health professionals, social workers, doctors and nurses, they were really pretty clear that for this type of education around elder abuse, family violence, for them, it just seems a lot more appropriate for it to be face-to-face than online. But having said that, we have online, modules around family violence. So we think that there is, importantly, there is a great potential for these resources, or the two, clinician-based resources, that there's a potential for them to be used to strengthen the focus of elder abuse within the current family violence online training, and also an opportunity to use them as a building block or to build specific elder abuse training. We think that, they would sit really nicely with face-to-face, the offers there for face-to-face professional development sessions that the social work team and the family violence team run currently, probably not so much during COVID, but hopefully now here's our opportunity. And at a more local level, maybe in informal, to use it at ward or department-based in-service programs. I think as a discussion starter, potentially, they're powerful. I mean, I've still got my goosebumps. And I think one of our great priorities, I guess, when we were building this resource, it was always with the idea of sharing them with other organisations. So, the offer is out there, Dominic. Excellent. Dominic's the Elder Abuse Liaison Officer at the Melbourne Health. Thank you for coming. So you know, we're very proud of these. Our study has developed, we think, a pragmatic, evidence-informed resources to support clinicians and older adults talk about and identify and respond to elder abuse. And we are so proud to have showcased them to you today. So thank you. And now back to Mai for some closing comments. There we go, closing.
Thank you. Thanks very much. It falls to me really to thank all of you for coming and for people online to join, and to just thank the remarkable team of people who've made this possible. I've taken a lot away. I think the issue of ageism is enormous, and we certainly heard that there was a sense of a lack of respect that came with that issue of ageing that actually made that heightened the risk, as you're saying, of elder abuse. And as a mother of 2 teenage girls who stood in Cotton On holding the credit card going, excuse me, I'm the one with the money, I absolutely identify with that sense of, you know, what happens in shops. But it's a hugely serious issue. And it is a real pleasure to see so many people here who are committed to this. And I think we take up that challenge we challenge ourselves when we think about the language that we use. We challenge ourselves when we think about stepping in and we hear other people sharing language that is inappropriate around older people. And we support each other to learn how we do this well. We have a population of patients. We know we will have more cancer patients over the next 10, 15 years, 20 years. We know that cancer is largely a disease of older adults. And so the risk and the proportion of people at risk within an organisation like Peter Mac, across the road, Melbourne, is growing. And so it is really behoving on us to develop the skills and our level of capacity to be aware and attuned to the risks that the people we come to work for every day is front and foremost at our mind. So thank you for your time. We've got a couple of minutes if anybody wants to ask any questions, or if you have any queries, very happy to take those. We will be having some refreshments outside afterwards, so if you'd rather ask anything informally, please do that as well. But if you have anything you'd like answered now, or you'd like to put to anybody, Jerry, yes, thank you.
So a comment as well. The UK have identified loneliness as a public health issue.
Absolutely.
So in thinking about what that means for Peter Mac and how can we address the issue of loneliness? So we have, you know, a number of peer support groups, our carer support program, but I was wondering about the Commission and how they can help us address loneliness. If there's any work you're doing about this.
Please come in.
Very good question there. I'm not sure everybody heard it. The question is about loneliness and observing what happens in the UK. Look, it is a challenging issue. It's hard to get a full breakthrough on that. It represents in so many different ways. So the main engagement at the moment is proactive ways of trying to get older people to connect at the local community level with groups like the U3As, men's sheds, etc. So that's a lot of the work that is happening very positively and effectively. Where we've had less success and there's more need for evidence-based research is once around about 10% of people move into the phase of chronic isolation and loneliness, that's where we need to do more work. And so one of the really important initiatives that will be occurring as part of the mental health reform is to look at the role of social prescribing. And so this will be an opportunity for the health professional and the health sector to look at. And what that means, and this again is an initiative from the UK, so I go to the doctor, I gave that example about walking out with the pills. Instead of walking out with the pills, I walk out with a list of local organisations who I could connect with. The critical thing is finding the right organisations and a pathway. See, if someone's already lost their confidence, what's going to inspire them to walk back into the room? So we've got to put some structure and roles around that. So watch out for that. That'll be a really important part of the rollout of the mental health reform, is looking for the social prescribing initiatives. And one of the target cohorts that the Royal Commission named is older people in that regard.
Jerry, if I might take advantage and mention that there's a project that we're just completing where we've developed a social determinants of health checklist, so that as people come into an organisation like Peter Mac, from the moment they enter the system, we ask questions about social isolation and loneliness. And those of you looking for a PhD, I think there's an opportunity here for a study looking at what happens when you intervene, when we identify isolation and loneliness early, and what happens to people's experience of care, and very importantly, their health outcomes. So thank you, a really important question.
Questions online.
Okay, thanks, Kathy. All right. Great, thank you. Well, I'm aware that I have a room full of very, very busy people. So Commissioner, thank you again for coming today and for sharing your expertise and putting in context our work. It's meant a great deal. So thank you very much for being with us. Karen, thank you for your time. I know how incredibly busy you are. It means a lot to have you here. And Andy, thank you too, as our Chief Nurse, for being here. And importantly, of course, all of you who've come and given up your time online and in the room, to the consumers who've travelled, thank you. And we hope that in the near future, we can report back about how we're using the resources and hopefully the impact that they're having. So I wish you all a safe journey home or back to work, wherever you're going. Thank you very, very much.